So we've done our ethane report, wearing appropriate PPE and utilising standard precautions. Kits are placed in 360-degree access. Hello, can you hear me? Hello, can you hear me? Patient is unresponsive to voice and painful stimuli. We're going to assess for catastrophic hemorrhage. There is none. We're going to check the airway, maintaining C-spine precautions. We're then going to assess, feel for a pulse, listen for breath sounds. Grant, can you please commence compressions? Going to turn on the monitor for the metronome, so as Grant can follow that at 100 to 120 per minute. Then going to confirm cardiac arrest and request backup of the highest clinical level. I'm going to expose the chest, making sure it's dry and hair free, and apply our defib pads. We're then going to charge the defib machine. Okay, Grant, I see, hands off chest. Grant, I see VFib. Do you see VFib?
Confirm VFib.
Okay, so hands off, all else clear. Administering shock. Then Grant, straight back on chest. Okay, we're then going to arrange, if possible, for IV/IO access. Whilst we're inserting our airway, going to be monitoring the end-tidal CO2 volume to ensure that we're administering high quality CPR. So we're looking at a range between 18 and 22. Grant, you going okay then?
Yes, I'm going fine, thank you.
Okay, so I'll get you to count me in. You're happy to do 15 to 1? Yep, fantastic. We've got our oxygen connected, high flow.
10, 11, 12, 13, 14, 15.
Fantastic. Okay, when we get to the 1 minute 50 mark,
15.
we're going to charge the defib again.
13, 14, 15.
Okay, hands off, going to assess rhythm. I see VFib. Do you see VFib?
Confirm VFib.
Okay.
Clear as well.
Clear, oxygen away, administering shock. We would obviously rotate our paramedics so that someone else is on the chest. I would be on this side, Grant would be on the airway. We would have also looked to administer IV adrenaline, 1 milligram, 1 in 10,000 with a normal saline flush after. We're going to be thinking about our reversible causes for cardiac arrest, so hypoxia, we can do airway management and O2. Hypovolemia would be an IV or bolus fluids and hemorrhage control. Hypothermia, we would withhold any adrenaline until the temperature is greater than 30. We would only shock twice and delay until the temperature increases to 30, so we'll be looking to warm our patient. Our drug administration, once the patient's temperature is up above 30, would be doubled to every 4th loop until the temperature is greater than 35. Hydrogen ions, so acidosis, we would manage with airway management and O2. Tension pneumo, decompression, and toxins such as a narcotic overdose, we would administer naloxone. Hypo or hyperkalemia would be ICP drugs and cardiac tamponade, and thrombosis, we'd be looking for rapid transport for a PCI in hospital. So we're obviously continuing compressions and ventilation, monitoring the ETCO2. A sudden increase in that would suggest to us that we've got ROSC, so we're going to assess for a pulse, obtain a temperature, look to get a BGL reading, also consider adrenaline infusion to maintain blood pressure greater than 100 systolic. We would look to do a 12 lead and monitor our SpO2 sats. Another drug that we can administer would be IV amiodarone, which we would do after the third shot, 300 mils and 300 milligrams, and then that would reduce to 150. We need to ensure that we've pressed our event button after administering the IV drugs, and rapid transport, and obviously considering as time progresses, considering our protocols for the cessation of CPR.